Roberts. So I'd like to invite Bethan up onto the stage to receive the award. So I'll just tell you a little bit about Bethan. Bethan's a final year training clinical psychologist. She's recently completing her dissertation and her degree in psych. This is her dissertation. It was conducted at the National Spinal Injury Centre at Stoke Mandeville, and I was a supervisor in terms of disclosure. But I wasn't involved in deciding who won the award. That was with the scientific committee. And it gives me great pleasure to support Bethan. As with a lot of research, our path has not been a straightforward one. So it's brilliant to be able to celebrate the research and the outputs and everything in this kind of forum, and to have that kind of recognition and things. So let me just over.
Thank you. So yeah, as Jane said, I'm Bethan. I don't know if you can see me. But thank you very much for having me. This is the first time I've presented a conference. So I'm kind of equally delighted to be here, but slightly nervous. So please go easy with me with questions and things. But nonetheless, thank you for having me. So as Jane said, I'm here to present one of my research projects that formed part of my thesis, my doctorate in clinical psychology. So we're looking at appraisals and life satisfaction judgments after spinal cord injury. And that's a comparison between people with spinal cord injuries, healthcare professionals, and the general public. I'm not going to labour this slide too much given the kind of expertise in the room already, but we know that there can be a lot of physical changes after a spinal cord injury and a psychological impact. So we know that there are higher rates of anxiety, depression, alcohol and substance misuse compared to those without spinal cord injury. And around 25 to 30% of people will go on to develop a diagnosable mental health condition. And there can also be short-term and long-term disruptions to social and vocational functioning. And I guess the big thing is that this is often a really abrupt onset that happens quickly and requires adjustment to a completely new reality without time for preparation. I am sure lots of you have probably seen this model before or know about it. So again, I won't spend too much time talking about it. But this is the spinal cord injury appraisal adjustment model by Jane and Paul Kennedy. So according to this model, when thinking about adjustment, the way an individual appraises the demands of the stressor, in this case a spinal cord injury, and their own resources to manage determines their coping response. So those that appraise their situation along the manageable kind of route up there have kind of feel like they have sufficient resources to cope, are more likely to use approach-focused coping, which tends to align more closely with adjustment and greater life satisfaction. So in contrast to that, that's the point. Where's the? In contrast, those that are more likely to appraise the situation as manageable or more as a threat are more likely to employ a kind of avoidance focused coping, and that's more likely to potentially lead to more secondary complications here. But another really important factor is the model identifies lots of biopsychosocial pre-injury factors that could be important in terms of previous kind of mental health, beliefs about self, about the world and coping, and lots of beliefs around I know Marcel kind of flashed some of these up. We might have an overlap of some slides, so bear with me with those. But it's good to know that our slides are aligning at least. So we know that whilst kind of psychological adjustment is variable in terms of people with spinal cord injuries, a lot of people demonstrate high levels of kind of psychological resilience. So as was said earlier, this study mapped symptoms of depression and anxiety across 4 different time points. So that was that injury, 3 months, 1 year and 2 years. And they identified, as I said, 4 different trajectories. And what they found was the majority of the sample of people in the study fit within this stable low depression trajectory. And that remained stable over the course of 2 years. And this group as well were also more likely than the chronically high depression group to endorse cognitive appraisals of the event as a challenge or versus a threat or loss. It's a similar picture when they mapped out trajectories of anxiety symptoms as well. So again, the majority in this study kind of fit into the stable low anxiety group. So there was a trajectory of low anxiety and a kind of flat, non-significant slope of change across time. And again, this group were less likely to endorse or appraisals of the event as a threat. And again, I won't flash this one up for too long because we've also seen this one as well. But in terms of mapping life satisfaction trajectories as well, we've obviously got the intermediate life satisfaction trajectory here from the start of rehab all the way across to 5 years after discharge, which was the most commonly endorsed life satisfaction trajectory. I'm not going to spend too much time on this because this has kind of already been covered in lots more eloquent detail. So, despite all of the previous slides in terms of mapping those trajectories of anxiety and depression and seeing that symptoms across time remained in that kind of stable, non-clinical areas, we know that when people without spinal cord injuries are asked to think about what it might be like to live with one of those injuries, we find that the judgments made tend to be overly pessimistic and negative compared to the lived experience of those who have sustained those injuries. And this is what we might refer to as this insider-outsider distinction. So in this case, the person with the spinal cord injury is the insider and people without the injuries are the outsiders. So perhaps for the outsiders, which is the people without injuries, when thinking about the life of somebody with a spinal cord injury, perhaps there's this preconceived bias that actually life is all defined by the injury, that it results in problems, lots of problems, that pose a challenge to experiencing life satisfaction or going about daily life. And in comparison for the insiders, which might be people with the spinal cord injuries themselves, maybe there's a view that the spinal cord injury represents one aspect of personhood, that actually there is absolute ability to go on and maintain normal life satisfaction. And I'll talk about it a little bit more when we get towards the end, in terms of what might be kind of influencing as well this insider-outsider distinction, and even a bit more around how disability or spinal cord injury is kind of portrayed in the media of stereotypes, how that just portrays the general public. To try and explain this kind of concept in a bit more detail, I've got a study here that Jane supervised, so please jump in if I'm kind of missing key aspects of your research here. But this was done back in 2001. So in this study, people without spinal cord injuries were matched based on age, gender and socioeconomic status with individuals who have spinal cord injuries. So initially, both groups were asked to rate their quality of life out of 100. So that is, so it was quality of life, value, and meaning of life. So that is this column here. So this is people without spinal cord injuries, and people with spinal cord injuries, which I didn't say. So this is, and what you can see between the two columns, sorry, the three different items, is that there were no significant differences between the two groups. So quality, value, and meaning of life was rated non-statistically significant between those two groups. And then another part of the study was people without injuries, so the non-injured group, were asked to predict how they thought a person with a spinal cord injury would rate their quality, value, and meaning of life. And people with spinal cord injuries, sorry, lots of words might be getting confusing, but people with the spinal cord injuries were also asked how they expected people without injuries would rate them. Does that make sense? Mm-hmm. Fabulous. What you can say, this is the predictions that were made by people without injuries when thinking about someone with an injury. That is a significant difference between the two, massively stark between the two. And I think this is really interesting as well when we think about how people with injuries thought the general public would think about what life must be like. And actually this tells us, this fourth column here, that people with spinal cord injuries are very aware of the negative views that people without injuries probably have about them, and what it's like to be able to live with spinal cord. I missed any bits, Jane.
No, Bethan, well done, because it's like not the easiest thing to present somebody else's research.
Okay. This is a slightly more recent study that I think kind of illustrates the same points again. I don't know if anyone's aware of this study by Morris. In this study, there was a sample of college students without spinal cord injuries, and there was a spinal cord injury group who were living in the community. So the people without injuries in this study were asked to imagine that 2 years ago they had sustained a spinal cord injury and they'd become paralysed. So they were then asked to rate the extent to which the statements would reflect the perceptions they think they would have. And they did that using the ADAPS, which I'm sure is quite familiar with as well. In this study, the spinal cord injury group then were asked to reflect on their current perceptions of their situation and of their injury. And again, kind of similar to the previous study that we flashed up, there was a significant difference on nearly every subscale of the ADAPS, just minus growth and resilience. So that was telling us that the group without injuries were endorsing significantly greater levels of negative appraisals than the people with the injuries. So again, there's this overestimation about how negative injury, life and situation is for people with spinal cord injuries. As the title kind of suggested, I'm also really interested in healthcare professionals as well. So it would make sense to bring in some research about what's going on with health professionals. Where do they stand in terms of this bias? According to this study, worryingly, not very well. So this is quite an old study now, but in this study, emergency room healthcare professionals felt that future quality of life of somebody with a spinal cord injury should be a determining factor in the medical interventions that they're provided with. Which is quite scary because quality of life was significantly underestimated. So only 17% of the healthcare professionals considered that a person with a spinal cord injury, and this was tetraplegia in this study, would have an average or good quality of life. And that was compared to that group who said 86% of us have an average or good quality of life. So again, a massively stark difference. And when the same healthcare professionals were asked to imagine that they had sustained a spinal cord injury resulting in tetraplegia, only 18% of them thought that they would be glad to be alive, And again, that was compared to 86% of spinal cord injury with tetraplegia, with that exact injury. So massive, massive discrepancies between the two. And this is, again, just a slightly more recent study, but in this study, healthcare professionals working in either inpatient rehab or long-term settings like care homes tended to overestimate the likelihood of significant mental health problems and poor adjustment. And this is kind of despite seeing those studies where the trajectory and symptoms remain in that low, non-clinical stable phase. And again, 80% of healthcare professionals in this study endorsed belief that quality of life is dependent on the level of injury, but despite research evidencing at least not a direct relationship between those two things, rather an indirect relationship through other factors. So, it might be kind of obvious and common sense at this point, but why is it problematic? Well, negative appraisals and beliefs about disability within healthcare professionals, particularly those are working directly with people with spinal cord injury, is really problematic. Members of staff in inpatient hospitals working in a rehab setting form an integral part of someone's social support network and resources whilst they're in hospital. And they're regularly involved in making treatment and intervention decisions. They are also perhaps heavily involved in scripting patients' expectations of what life might be like. How is life going to be when I leave this hospital? Am I going to be able to cope? Am I going to be able to manage? So staff have a really key role in conveying that manageability to patients that are with them. So, healthcare professionals may negatively impact beliefs formed by people with spinal cord injuries about their own injury and their capacity for growth and life satisfaction, which feels a bit problematic. So, this leads me on to my study, the study that Jane supervised. So, these are the things that we were really interested in finding out. So, whilst there's some research exploring judgments about life after spinal cord injury between healthcare professionals and people with spinal cord injuries, there's really limited research with professionals working directly with that group. And nor has a comparison of appraisals and quality of life judgments between the two groups been explored. So that leads me to our research questions. So we were really interested in finding out whether there was a difference between the appraisals made by these three groups and thinking about life after spinal cord injury. And we were also really interested in finding out whether there was going to be a difference in quality of life judgments between these three groups. And we predicted that there would be, based on the previous research that we've just spoken through. So we predicted that the general public and the healthcare professional group would make more negative appraisals of life after spinal cord injury than the spinal cord injury group. We predicted the same for quality of life. So we predicted that healthcare professionals and the general public would also predict poor quality of life in comparison to the spinal cord group. You have to just wait to find out the results, but they're coming. Okay, so who is in the study? We obviously needed three groups to explore differences between three groups. So the spinal cord injury group, as Jane kindly mentioned earlier, thank you, was recruited from Stoke Mandeville Hospital. So of course people needed a diagnosis of a spinal cord injury. That could include incomplete injuries as well. We put a minimum number on the weeks after an injury where somebody could participate. I think that was to allow for kind of mood stabilisation not being right at the acute phase. And as an exclusion criteria, we removed anybody with kind of moderate to severe organic or non-organic brain injuries, I guess around that person's ability to consent or understand the study tasks. And then we had a healthcare professional group. So these are healthcare professionals working at Stoke Mandeville Hospital in the UK. They could be of any profession as long as there was contact with people with spinal cord injuries. The only profession we excluded was psychologists. Because of the likelihood of their knowledge already around this inside-outsider distinction, and the fact that abstract manual, this kind of training, exploring this topic is delivered to other members of staff. So sadly, psychologists were excluded from the study. And then we also had a general population group. And again, we excluded people, again, working in the psychology profession, or people who were currently working or had worked in a health and social care setting with people with spinal cord injuries, which kind of be a slight blurring between this boundary here. So those people were excluded. I will speak a little bit more about how we did this in a couple of slides, but the groups of participants were age and gender matched. The age limits for the study was between 18 and 65. Because we were recruiting a healthcare professional group, we were suspecting at this point there might not be that many people. We'd hope over 65 still grinding away in the NHS. So we had an upper limit in terms of age. This is the design. So everybody in this study, regardless of group, did exactly the same thing. So initially we asked for some basic demographics, and they completed a PHQ-4 mood screen. And then everybody read a clinically informed vignette of Steve. So Steve was a man who sustained a spinal cord injury resulting in tetraplegia following a car crash. I'll come back and talk a bit more about Steve and where that vignette has come from in a few slides. But this was the vignette that all of the groups read, same thing for every single group. And then we asked participants to complete 2 questionnaires, and the key bit here is based on how they thought Steve would think, or appraise his injury, his situation, and his quality of life. So they're imagining, what's Steve going to think? And we used 2 different questionnaires to do this. So we had the appraisals of disability primary and secondary scale, and we used the short form version of the study. And we also used the spinal cord injury quality of life basic data set measure as well. And that was version 1. I'll come to talk about these measures a little bit more. Okay. So in order to ensure that we were able to age and gender match properly, we recruited the spinal cord injury group first. Because that was the most limited sample in terms of numbers and in terms of people that might hit the eligibility criteria, we recruited this group first and then went out to healthcare professionals and the general public afterwards. So just some basic bits of how people were recruited. The amazing clinical psychology team did lots of looking through the patients that were at Stoke Mandeville and looking to see who was eligible. People were given flyers, participant information sheets attached to rehab timetables, and then we would come if participants were interested and take informed consent. For the spinal cord injury group in this study, they could either complete online or paper, depending on preference, level of ability, access to technology. The second phase, like I said, was when we went out to healthcare professionals and the general public. So we recruited by email, department visits, bribery with chocolate or cake, posters, and to ensure that we were able to match, there was some purposeful sampling, so roughly kind of approaching people that fitted the right age and gender profile. Whilst we are acutely aware that is not necessarily the most robust way to sample, it was felt that it was a kind of methodological trade-off to make sure that the groups were adequately matched, that we could control for that potential confounding variable. And then the same for the general public group, that was recruited via social media, Facebook, Instagram, and again some purposeful sampling. And this was online completion for these 2 groups. So this is the vignette. The vignette that was used in this study was previously used in the research that I mentioned that James supervised. And it was based on a patient's experience of injury that was anonymised and refined through consultation with lots of people with spinal cord injuries and healthcare professionals working in different disciplines in spinal cord injury rehab. As the vignette was developed back in 2001, for our current study we updated it so that it would reflect clinical practice. So the previous vignette talked about conservative bed rest versus surgery options. The original vignette as well also mapped a person's experience to years after their injury, whereas for the purpose of this study, we kept it to a 6-month mark, so at the point of discharge. And that was more closely to align with kind of average hospital stays now, but also to more closely match with where our spinal cord injury participant group were in terms of their own rehabilitation kind of journey. And the vignette we used was also, adapted through a draft iteration process, so consultation with Jane, but also people with spinal cord injuries at the ESPA. I don't know how we're doing time. I think that might be a bit small to read. 10 minutes. 10 minutes left. Okay, I'm going to skip this, but essentially this is the vignette that we use that all of the participant groups went through. Demographics, we collected age, gender, ethnicity. There were some injury-specific things we were interested in finding out, so type of injury, level of injury. For the staff, we wanted to know about job role, length of time working with people with spinal cord injuries. We were also interested to find out whether staff or the general public had a family member or a close other with a spinal cord injury. That wasn't an exclusion criteria, we were just really interested to know if people had much contact with somebody with spinal cord injury. I'm sure you've probably all seen the PHQ-4 before, but this was our mood screen, so 2 questions from the GAD-7, 2 questions from the PHQ-9. Again, I'm sure you've probably seen this measure as well, but this is the short form ADAPTS that we used in the study. So it has 6 questions from the full 33 item ADAPTS measure, and 1 question corresponds to each theme from the full ADAPTS measure. And the items in red correspond into this loss factor, and then the items in green correspond to this resilience factor, so are grouped together. This is the quality of life measure that we used. So people were asked to think about rating their life satisfaction on a scale of 0 to 10 for their life as a whole or overall, their physical health and their psychological health. So 3 different questions. This measure, as I understand it, was developed by ESPA, and it was to standardise the collection and reporting of the minimal amount of information that was necessary to be reported in research, so it's possible to evaluate and compare results of published studies. This one is version 1. This is the one we used in our study, but we're aware as well that there's a version 2 that has an addition of a 4th question that is to do with satisfaction with social life. These were the results. Sorry, there's quite a lot of graphs and tables, so bear with me. This is just our demographics of our participant groups. So, we had 21 people in each group, so we did a power analysis, and that was the kind of minimum amount needed for each group. For the 3 samples, the most common ethnicity was white British. For the spinal cord injury group, the average time since injury was 10 months, and the most common level of injury was spical, and overall level of injury ranged from C3 to T11. The time spent in the staff characteristics, the time spent working with people with spinal cord injuries was a mean of 6 years, but that varied from 1 month to 22 years, so we had a real breadth of experience. And the most commonly represented job roles was therapist. So firstly, we wanted to check whether we matched our samples properly and that it actually worked. So the statistics that we did there suggested we got it right. So we had no differences in age across the 3 groups, and gender was matched across the 3 groups too. So we managed to kind of control for those potential confounding variables. We had hoped initially to use the PHQ-4 and enter it as a kind of covariate to see whether appraisals and quality of life ratings were in some way influenced by mood. Sadly, we didn't have enough statistical power or enough people in the study to be able to do that, so we couldn't do that here. But what we did find was there was a significant difference in the PHQ-4 scores. So you can see from the leads here that the spinal cord injury group were reporting significantly higher ratings than the staff and general public, although that was still within mild range of symptoms compared to healthy range of symptoms here, so still quite low levels. Okay, so back to the original research questions. So we were interested in finding out whether there was a difference between the appraisals between the 3 groups in response to this vignette about life satisfaction. So what did we find? We found that there was a difference in terms of the loss factor. So the general public considered the person in the vignette, Steve, would endure significantly greater loss appraisals than the spinal cord injury group. But no other significant differences were observed, so nothing between spinal cord injury and HCP or staff group. In terms of the resilience, we didn't find any differences here between the 3 groups, just in the loss factor of the adaptation. In terms of quality of life, we found a mixed picture. So there was no differences between the groups in the ratings of life satisfaction overall. What we did find was, in terms of satisfaction with physical health, the general public predicted that ratings would be lower compared to both staff and to the spinal cord injury group. And in terms of satisfaction with mental health or psychological well-being, again, the general public predicted lower ratings, or predicted Steve would think more negatively in terms of his life satisfaction compared to the spinal cord injury group. I might just whiz through this quickly, just with time. In terms of what we predicted, we partially found it. We found that the general public were more likely to think that Steve would have more negative appraisals and would more negatively rate his quality of life. But we didn't find any differences between spinal cord injury group and the staff group. And the same was true for, oh no, I've done the slides backwards. So that was the appraisals, and this is the quality of life side. So we didn't find that there were any differences between the healthcare professional and the spinal cord injury group, but there were differences between the general public and the spinal cord. So, what's going on? What's happening? So, it's estimated in the UK that the prevalence of people living with spinal cord injuries is around 50,000, and that's in a population size of around 67 million. So that's a really small percentage of people. So given this low prevalence, most individuals in the general public might have sparse to no contact at all with somebody with a spinal cord injury. That might limit opportunities to learn about both the positive, negative and challenges associated with living with a spinal cord injury. And as a result, perceptions of disability might be shaped by different things, negative media or societal stereotypes, narratives, or perhaps even just the absence of representation in the media at all. And research has told us even when disabled people are included in the media, coverage can be harmful. Media portrayals can frequently serve just to reinforce existing public misconceptions. They might use inappropriate or insensitive language or terminology and might acutely focus in on medical features of disability rather than the individual itself. And I'll just reference, I don't have time to go into it, a really great study that was done in America, in Australia, exploring media portrayals of spinal cord injury. And they pulled out a number of different themes where people are saying, you're a sufferer and you need to be pitied if you have a spinal cord injury. And pity was described alongside terms like tragic or sad. And also, media perpetuates a misunderstanding. So someone was quoted to say, I've been described as suffering from paraplegia, but I haven't suffered, I'm just doing normal things. And again, this might be really obvious, but why is this really negative? Biopsychosocial models of disability recognise how living with the disability itself is less impacted by injury, but rather with interactions with family, educational institutions, and workplaces and communities. If there are biased kind of preconceived notions in the general public that this person might be despondent, struggling to cope, or consumed by their injuries, that could well limit social and vocational opportunities for somebody. And on a much wider and perhaps more profound scale, this could influence how disability is discussed in the general public or by policymakers that have the ability to allocate resources. And all of that can impact a person's ongoing adjustment and community reintegration. So with this really quickly, we expected that there would be a difference between the staff and the spinal cord injury group, but there wasn't, which is not what we expected, but it is an important finding nonetheless. And so the process of rehab requires often lots of difficult, complex treatment decisions, and people will seek guidance from the healthcare professionals around them. And we know from previous research that interactions with healthcare professionals working in rehab has the ability to facilitate hope or autonomy. So we think that it's kind of important and encouraging actually that the views of the healthcare professionals in this study are more aligned with the spinal cord injury group. I'm not sure I have time to go into this.
Just the reason why we're interested is, when Bethan has yet to defend her dissertation, and I've just thought of a reason for. So we present on this regularly when we do staff inductions at the NSIC, and we didn't present on it during the time of Bethan's research, but the previous staff have had information about this, so that might have biased some of the responses. So when I'm doing, I consistently, when I do training, present on it, and we consistently find that people with healthcare professionals rate people's experience of spinal cord injury more negatively than their own quality of life. So that was just to show some of that.
Thank you. I won't go into this just because of time. No research is without its flaws, and definitely there are areas where, of course, this study could be kind of critiqued. We were wondering about the brevity of the measures that we used. We were trying to reduce the participation burden for our spinal cord injury group, but we wonder whether more brevity in the measures we use might have pulled out more nuances between the three groups. Of course, it's a vignette design that has pros and cons, but it is really difficult for a static vignette to represent the dynamic reality of what it is like for a person to live. And that's kind of the point that you were talking about there, Jane, I think, that maybe our healthcare professional group might have had service-specific training, or it might represent a kind of progressive culture and views on disability. The majority of participants in the staff group were therapists, so we wondered whether there could have been a difference in terms of how therapists versus nursing staff, for example, have a different kind of ethos or treatment approach towards people. And again, predominantly white British samples, so of course there's lots of differences in terms of different cultural views on disability. But I'm going to stop there. Thank you very much for listening.
Time for one question. Yes, go on.
maybe more of a reflection, but I guess interestingly, after my sales talk we went at the start, I wonder if you've had any thoughts about how different it might have been if you were asking people with spinal cord injuries longer into their injuries, because my sense of working in a hospital is that people's idea of life is actually kind of suspended whilst in a hospital, so quality of life is quite limited in that sense. Okay.
Yeah.
Do you have any thoughts on that?
No, absolutely. And when we first designed this project, we wanted to have a group that was within an inpatient setting and to follow up with a community group. I think through the process of developing a project that was perhaps feasible in terms of the doctorate, it wasn't possible, and we had to make a lot of changes, which is sad because I think it would have been really helpful information. But yeah, I think that's a really valid point. I wonder.
And we also wanted, ideally, our original design was people with paraplegia, people with tetraplegia, and people with incomplete injuries, because talking with people with those different injuries, they each perceive the other to be luckier or different, or so it's ripe for future research.
Yes. It's a PhD project, it's there ready to go. But yeah, that's a really great question. Yeah, thank you.
And actually, sorry, this is not being time, but after what you said, the other thing I was thinking was that I used to work in cleft lip and palate, and actually the quality of life comparisons in other conditions seem to work the same way as well. So not just spinal injury, but people who don't have the condition think it's worth to do it. So yeah,
Absolutely. And I think the inside outside institution obviously has been applied and used in terms of thinking about lots of other kind of chronic conditions or visible difference conditions. So yeah, absolutely.
Bethan, thank you very much.
Thank you.